Hello, everyone. Very nice to see you. And we have very interesting case to discuss today. This is a multidisciplinary team approach. We have physicians from different specialties, and we have a case of cardio-renal syndrome, acute decompensated heart failure. We are going to discuss how to precisely and properly treat this case. My name is Amr El-Husseini. I'm a professor of nephrology. We have Professor Hesham Elsayed, Professor Hosam Arafa, Dr. Craig Arnsey, and Dr. Rola Osman. And let's just go and start our case discussion today. We have Ms. Sarah, who is a 67-year-old female patient with a past medical history of heart failure with ejection fraction around 45%. She came into our emergency room with difficulty breathing and weight gain, and she had an increase of her serum creatinine from a baseline of 1.5 to 3.2 milligram per deciliter. Her blood pressure was 110/75. Her oxygen saturation was 85% on room air, but was up to 93% on 5-liter nasal cannula. She was on losartan, beta blocker, atorvastatin, torezumide 40 milligram daily at home, but she has not been urinating well in the last couple days.
Seems heart failure patient is saturating with worsening renal profile, decreasing urine output, needs a lot of workup, but looks like she has volume overload and needs diuresis.
Absolutely, Rola. So you are feeling like she is probably having cardio-renal syndrome and want to diurese her. But what about the degree of her acute kidney injury on her CKD? I think this, makes this case is a challenging case, and your team is a little bit queasy about pulling the trigger and how to manage her other medications.
Yeah, this sounds very familiar, especially with that creatinine soaring up from 1.5 to 3.2 milligram per deciliter range. I think makes anyone really nervous.
That's true, yes, it would make me nervous as well. But this is a very common occurrence, and it is usually very obvious to identify this based on clinical evidence. In this instance, the most obvious mechanism is actually an acute fall in cardiac stroke volume, leading to the spectrum of pre-renal disease, acute kidney injury, and even ischemic ATN.
I think a lot of people get that when there is low cardiac output that causes a pre-renal acute kidney injury, since the heart is not pumping enough blood forward to the kidney. But how do they get congestion without that cardiac output problem, leading to that cardio-renal picture?
Yes, so the recent studies have postulated that an increased central venous pressure is the critical factor. However, there are other factors involved, as we know, with the inclusion of the activation of the renin-angiotensin system, the activation of sympathetic nervous system, which all are focused around, obviously, the mechanisms of salt and water retention. So targeting these mechanisms of salt and water retention gives us a good clue as to how to effectively treat the syndrome, that being RAS inhibition, sympathetic nervous system blockade, as well as diuresis.
Exactly, Craig. I fully agree on that. Let us expand our multifactorial effect on these patients. So when we talk about congestion, there is extra pressure on the venous side of the renal capillary bed. Such a kind of pressure where the blood is leaving the kidney. The venous congestion makes it more difficult for blood to travel through the kidney itself. Subsequently, the excess of the blood on the venous sides gets jammed up.
Yeah, so it is quite possible and probably more plausible that multiple mechanisms are involved simultaneously. So you cannot just assume that your patient may not have some kind of underlying interstitial kidney disease or possibly even a glomerulonephritis. Anything is possible, and that is why we always have to go through the usual process of diagnosing the underlying cause of the potential kidney disease as well as the potential cause of heart failure.
Absolutely, Craig. I completely agree with you. And I think the theory of the renal tamponade or the hypothesis to explain the disproportionate impairment in renal function with increased central venous pressure in patients with congestive heart failure. So now the renal capsules around the kidney is very rigid and will not allow expansion when pressure rises. The increased central venous pressure lead to increased renal interstitial pressure, compressing the renal parenchyma with the renal tubules, interrenal veins, and glomeruli in the encapsulated kidney. Ultimately, renal decompression therapies with using diuretics or ultrafiltration is the best option to treat this congestion with worsening heart failure and kidney failure.
Exactly. Please put in mind as well, in type 3 and 4, as you know, cardio-renal syndromes are more likely results from volume overload from renal dysfunction. However, abnormal cardiac function in the setting of metabolic disorders, like, for example, acidemia and neurohormonal changes that can and accompany renal diseases, adding a lot on such a progress of acute kidney injury.
Mhm. So between cardiorenal and renal cardiac, acute or chronic, there is no definite demarcation, and usually there's an overlap. Also, we have type 5 cardiorenal syndrome where there's systemic disease affecting both of them, like systemic lupus and diabetes mellitus. All vital organs of the body share biological information, which is termed organ crosstalk. And heart and kidney, of course, dysfunction can be observed in many hospitalized patients with organ crosstalk, especially in the intensive care unit.
Exactly, Aurora. You are completely correct. So, in cardio-renal syndrome, it can be either the heart or the kidney and cross-talking between. The relationship may be bidirectional depending on the case, or maybe something else entirely affecting both at the same time. That's affecting the organs in parallel.
Yes, Professor Dr. Hesham. I always say when we understand the pathophysiology, management will be much, much easier. Let's go back to Mrs. Sarah. Her creatinine is going up. She has some cardiorenal physiology, either from venous congestion and or contribution of both forward flow and the low flow. But how can we feel sure about this except getting urine volume assessment? Should we order cardiac or renal biomarkers, imaging like echo, focus? What else can we make us feel sure?
I think that's very good questions, Rola. I cannot emphasize more on this. The volume assessment is very crucial and always challenging in our ICU patients with both heart failure and kidney failure. This is the reason that we frequently need point-of-care ultrasound and use biomarker like brain natriuretic peptide and the N-terminal pro-BNP to judge on volume status and also on the response to medical management. The biomarker do not only have diagnostic value, but also prognostic value as well. Okay, guys, now it's time to ask questions. And I have Dr. Alia El-Hamrawi from 6 October Insurance Hospital in Cairo, Egypt. She's going to help us to answer these questions. And also she's going to help us how to better manage our patient. So the first question we have is about the cardio-renal syndrome biomarker and which one of these statements regarding cardio-renal syndrome biomarkers is incorrect. So we have 5 choices, 4 of them are correct and 1 is incorrect. Choose the incorrect one. The first choice is plasma natriuretic peptide concentration have been shown to rise in parallel with decreased renal function. Second choice is combination of an elevated N-terminal pro-B-type natriuretic peptide and decreased renal function with GFR less than 60 is a predictor of 60-day mortality in acute heart failure patients. The third option is reduction of NT-proBNP level during treatment of acute heart failure patients has not been associated with improved outcome in patients with reduced renal function. Fourth choice is cystatin C level may increase in patients with thyroid dysfunction, obesity, corticosteroid therapy. And the last choice is KDIGO guidelines recommends the use of cystatin C when the presence of renal dysfunction cannot be confirmed by serum creatinine levels alone. What do you think, Alia? Which one of these statements is wrong?
Okay, I think it's number C, because the reduction of NT-proBNP has actually been proven to have a positive predictive value. Here, the question says, or the structure says, has not been associated with an improved outcome. Actually, it has been. It's one of the biomarkers used to predict the outcomes.
But remember, this option C is saying in patients with reduced kidney function. So do you think that this positive predictive value is the same for patients with normal and with abnormal kidney function?
I think it's one of the biomarkers used.
Very good, very good. Let's discuss this in details. And Alia is right. Reduction of the N-terminal pro-B-type natriuretic peptide levels during treatment of acute heart failure has been associated with improved outcome in patients with reduced kidney function. So as you know that the diagnosis of heart failure and chronic kidney disease relies upon signs and symptoms of both cardiac and kidney failure together, along with abnormalities of the structural and functional changes. And the biomarkers add further information on cardiac and kidney damage, given their diagnostic, prognostic, and predictive value. So we have very good biomarkers we can use to reflect what's going on in the kidney function and in the heart function as well. Among of these biomarkers, or one of the best biomarker we have, is a natriuretic peptide, especially the B-type natriuretic peptide and the N-terminal part of it, which has been recognized as one of the best biomarker in patients with acute and chronic heart failure, in patients with normal kidney function, and in patients with chronic kidney disease as well. Elevated N-terminal pro-BNP over the BNP, so when the ratio is higher, it reflects the acute decompensated heart failure and impaired renal function in patients with Cardio-Renal Syndrome. It's not only diagnostic, but also has a prognostic significance. So patients with higher ratio have also bad outcome. And the plasma level of the natriuretic peptide have been shown to rise in parallel with decreased renal function and with progression of CKD to end-stage kidney disease. And the combination of elevated NT-proBNP and reduced GFR is a very good predictor for the 60-day mortality in patients with acute decompensated heart failure, and the reduction of the NT-proBNP level during the therapeutic course of our patient with congestive heart failure has been associated with improved outcome, even in patients with reduced kidney function. So use this biomarker. It's very helpful. Of course, the cornerstone of the management is the clinical symptoms and signs, how the patient improves, the urine output, the congestive symptoms, but also these biomarkers are complementary. And among these biomarkers of renal function, the serum creatinine and eGFR are largely used in patients with renal impairment for both diagnostic and prognostic purposes, but there is limitation in patients with heart failure, and sometimes actually with hypervolemia because of the hemodilution, the creatinine doesn't reflect the kidney function, and also because of the sarcopenia that our patient with congestive heart failure have. So it can overestimate the kidney function. So serum creatinine may not actually reflect the real GFR, and it could actually give a false estimate about 20% higher GFR. So this is the reason that sometimes we combine use of cystatin C with the serum creatinine to give us better estimation of the kidney function, especially if the patient has loss of muscle mass, or patient was underweight, or patient with severe sarcopenia, or very low BMI, or very high BMI as well. But as you know, patient with thyroid dysfunction, patient who are receiving corticosteroids can also impact cystatin C. So the combination of serum creatinine and cystatin C might be a good combination to check on the real kidney function. The KDIGO guideline said use cystatin C. They recommend its usage when the presence of renal dysfunction cannot be confirmed by serum creatinine level alone. Here are some references if you are interested to read more about this biomarker. I think these are very good references to read and to get yourself familiarized about cardio-renal syndrome biomarkers.
That's great, focus and other biomarkers of bedside testing of these biomarkers for volume overload status. So let us go back to Miss Sarah. She seems volume overloaded, but thankfully not looking like a patient who's really in cardiogenic shock. However, she is congested, maybe an impending pulmonary edema as well.
Yes, Professor Dr. Hesham, she's not in cardiogenic shock. Her blood pressure 110 over 75 millimeter mercury, maintaining saturation on 5-liter nasal cannula. She's on volume overloaded, as you said, maybe she's impending pulmonary edema. I think we should start diuresis. That may help her to feel better and get more blood moving through her kidneys. But I need to go into some practical points and tidbits on intravenous diuretics.
Yes, it's a cornerstone in the management of such a patient, Rola. So I know based on the dose trial, we can feel safe with an aggressive approach of taking her home diuretics dose and give 2 to 2.5 times that amount by IV dosing per day while she was in the hospital. She is on torsemide 40 milligram at home, so that would be aiming for around 160 to 200 milligram IV Lasix throughout the day.
I don't know if you've noticed, Dr. Hesham, that it seems cardiologists and intensivists like giving infusions, whereas nephrologists are more in favor of giving bolus doses of Lasix. I personally believe that it's got more to do with the timing of when you administer the Lasix, especially in the context of your patient having low albumin levels or low blood pressures, which, if those are present, usually doesn't cause the Lasix to give a good diuretic response. Dr. Amr, I wonder, I would be interested to know, how do you prefer to do Lasix, as an infusion or as orals?
Okay, thank you so much, Greg. I think that's a very challenging question. And I reviewed this subject very recently, and I didn't find any study that has any preference between both. I have my own reason for liking bolus dosing more. It gives the macula densa a bit of break. But again, it's a personal preference, and it's good to know that there is no study that has shown superiority of one over the other.
I agree completely. And what you said is, it sounds like a very healthy thing for the kidneys, and that is to give the macula densa a break. So I suppose the next question is, do you have a preference of which drug to use between furosemide, torsemide, and bumetanide? Please give us your thoughts of how you would choose the right drug for the right patient.
Again, thank you so much for this interesting question. Until recently, we have only oral torsemide, but now we have the luxury to use also IV torsemide as well. I don't think there will be such difference between IV and oral torsemide, because the bioavailability of torsemide is very good, which is very different from Lasix. Lasix actually the bioavailability is about 50%, but when it comes to torsemide, it's up to 100%, so it doesn't make big difference to give oral or IV torsemide. I personally don't think there is any difference in IV furosemide or IV bumetanide, except for that the IV bumetanide allows us to give higher loop diuretic dose compared to the IV furosemide.
I think one other difference we should point out between furosemide and bumetanide is that bumetanide drip can give terrible myalgias and diffuse pains, despite bumetanide might be preferred in some studies compared to furosemide with regard to diuretic resistance.
Okay, I always hear this complaint, a common complaint. I'm taking my furosemide, but I'm not just urinating just like before. I'm edematous and gaining weight, even with increasing the dose. Repeated words, particularly with furosemide being less bioavailable, much less bioavailable than furosemide and bumetanide. This is a common complaint we face always.
Yes, Rola, it's a very common practice on the everyday practice in the clinics and the hospitals. So let us recap something of the important points, and we will move to Dr. Hesham to correct me. So oral furosemide bioavailability between 10 to 90% from 100%, with 50% on the average. Please correct me.
Yes, my dear Dr. Hesham, I did know that the bioavailability was all over the place with furosemide, but I did not know it could be as bad as 10%.
So we have here good news, Dr. Hussein, that oral furosemide and bumetanide have a bioavailability that is usually above 80%. However, I think that would make anyone feel like these are more reliable. Can I hear from you, Amr?
Absolutely. Again, the pharmacokinetics makes a lot of sense. Furosemide has a longer duration of action, up to 16 hours. It's more predictable in terms of bioavailability when it comes to compared to the oral dosing. And there was a study on this called the Transform Heart Failure Study. When they compared furosemide to furosemide, I thought that this study is going to show superiority of furosemide, but sadly, actually furosemide and furosemide were very similar when it comes to the patient outcome.
Yeah, my dear friend, I agree. Despite the pharmacokinetics, when we studied this in real world, there was no difference in patients who were hospitalized for decompensated heart failure and were discharged either on oral torsemide versus oral furosemide.
Well, thank you for all of that, but for me, the question still remains. Would we get a better diuretic effect from a longer acting agent like torsemide, which lasts for up to 16 hours, as we've said? Or could we get the same benefit from good old Lasix, which only lasts 6 hours? Alternatively, can we get an even better effect from a short-acting bumetanide by giving strategically more frequent doses over a 24-hour period?
Dr. Craig, it's a nice question. There's no big difference between intravenous furosemide and bumetanide regarding duration. It's not a problem of duration, but bumetanide is much more potent milligram per milligram. So it is easier to reach her for a higher doses, equivalent doses.
Thank you, Rola. So there's one more interesting fact that I read about torsemide, and that is that it causes considerably less potassium depletion. And in turn, this turns out to be a very big beneficial effect because given its aldosterone antagonistic effect, it causes less hypokalemia than the other diuretics, which in fact makes it a more potent diuretic effect. It really seems like torsemide wins this diuretic choice from multiple levels.
Very good, Alia. Let's move on to the second question. So our patient, Ms. Sarah, presented with acute decompensated heart failure and rising creatinine, worsening kidney function with low urine output and severe congestive symptoms. Which of the following is the next best step in her management? Would you like to prescribe loading dose of intravenous Lasix, then give intravenous infusion of Lasix? Or do you like to continue the oral furosemide? Or do you like to start furosemide IV infusion along with 5 milligrams of metolazone, or prescribe isolated UF, or start metolazone monotherapy? What do you think, Alia?
Okay. I think a patient with acute decompensated heart failure is hospitalized and needs management with a drug that has good bioavailability and effect. Torsemide is known to have a good bioavailability, but this is actually an emergency case that needs admission with rapid action. And IV, I agree with number one, with A, because I think IV torsemide followed by intravenous infusion would give a good urine output and good effect.
Very good, very good. I think I agree with you that the correct answer is E. So we need to give IV Lasix and start IV infusion of Lasix. This patient is probably in severe congestion in the ICU, and we need to decongest this patient. So again, this patient doesn't need ultrafiltration. We still need to optimize the medical therapy. And we can optimize the medical therapy either with torsemide or furosemide. Torsemide is very potent. Its bioavailability is actually very good, 80 to 100% compared to about 50 to 60% of Lasix. But the IV Lasix in the ICU setting start with boluses, then maintain the patient on infusion of Lasix, I think would be the best option. And the guidelines suggest using 2 to 2.5 times of the home dose of Lasix. So we can double the Lasix, then start bolus, then keep the infusion. Torsemide could be changed to an equivalent dose of furosemide or Biomarker as well. But I think at least we need to start IV diuretics either with the Lasix or Biomarker. I want also to let you know, Alia, that small studies have shown better immediate outcome with torsemide, but the RCTs, the big randomized clinical trial, didn't show any impact of torsemide compared, of course, to Biomarker or Lasix on the long-term outcome or the mortality. So
I think torsemide actually has a worse or increased mortality in 150 days. In acute decompensated heart failure patients. So
compared to what?
Torsemide compared to Lasix in acute settings of acute decompensated heart failure, they have similar outcome of 30 days, but actually higher mortality rate in 150 days. So,
I mean, the big RCTs didn't show any survival benefits when we compare torsemide to furosemide. So IV loop diuretic should be administered, I think, in this case, and should be administered as early as possible, since early loop diuretic administration is associated with lower in-hospital mortality. In the dose acute heart failure study, no difference was seen in the primary endpoint between continuous or bolus infusion. However, if you want to do infusion, you need to give bolus doses first. You cannot just start with the infusion. You need to bolus the patient. If you bolus the patient, doses should be split up into doses with at least 6 hours interval to maximize the time above diuretic threshold and to avoid rebound of sodium retention. That's very important. Continuous infusion should be preceded by loading dose. That's very important take-home message. So in the studies when they used the Lasix without bolus, just use Lasix infusion, the outcome were very poor. The other option is to start metolazone with Lasix. Metolazone can block the distal convoluted tubule sodium reabsorption along with the Lasix, but not in a replacement of the IV furosemide. So IV furosemide is the cornerstone of management, then can be combined with metolazone or aldactone.
Yes, as a next
or-
step, and even the ultrafiltration is a next step if IV Lasix did not give a good response. So the question was, what's the initial next step? So that's why we start with IV furosemide, followed by other options are not wrong, but they would follow this if there is no effect seen.
Agree. I want also to let you know, Alia, that in the CARES heart failure trial, addition of metolazone was a very important step forward in the pharmacologic algorithm, and the results of using the thiazide diuretic as a second-line agent in Heart Failure Society of American practical guidelines. Now they are including the thiazide-like diuretic, which is the metolazone, in combination with the loop diuretics. And again, torezomide is proposed to be a very strong diuretic, but the clinical outcome study, especially the Transform Heart Failure big RCT that was published this year, didn't show a difference compared with the Lasix. The greater natriuretic effect of torezomide has been counterbalanced by increased neurohormonal activation and upregulation of the neurohormones and the kidney dysfunction that happened to this patient. So this Transform Heart Failure study didn't show any significant difference between use of torezomide and furosemide. Again, here are the references. They are very updated with the most recent studies, and including the Transform Heart Failure study that comparing torezomide to furosemide.
So back to Mrs. Sarah, I'm wondering, how do we know if we are getting the proper diuretic response? We want just a clinic, we will follow just the clinical points by following flow chart, input and output chart. Are there any other special tools?
Good question, Rala. All those times where the patient morning weight is up and down, I mean, it's staying up and down, or the patient is charted net negative 1.5 liter, but that's shared to believe they only passed 200 cc, which I do not know about that.
I must say, I'm a bit of the old school when it comes to assessing the effect of the diuretic. I usually weigh the patient before and after about 6 hours after giving the diuretic. And if there's not been much happening, I just double the dose of the drug. I've also heard of people doing spot urine sodium measurements after about 2 hours of giving the diuretic. And apparently an adequate response is defined as a urine output of between 100 and 150 mils per hour during the first 6 hours, or a urine sodium content of more than 50 milliequivalents at 2 hours.
Yes, correct. I believe in that, and I agree that on this approach. And you should have the patient's empty bladder before giving the diuretic and then collect this sample. It is in the ideal world.
Yes, and there are other factors that also make this urine sodium measurement a bit unreliable. In particular, one must be aware of the concomitant drug use, especially the use of bicarbonate administration or other medical causes for metabolic acidosis. Certain antibiotics also interact, like piperacillin and tazobactam and other aminoglycosides. And this can give you a falsely high urine sodium, which makes you think that your diuretic effect is highly effective. But as always, one must remember that no matter how much diuretic you can give the patient, you cannot expect a response from a kidney that, for instance, has ATN, or for that matter, some kind of obstructive uropathic process.
Yes, thank you very much, Kate, for highlighting such antibiotics and this conflict. So maybe go back to the larger hidden message in all of that, which is the urine sodium is just one data point and needs to be taken into context of total output, additionally weight, symptoms, and all of that. But at least it is not an objective data point that can give you some more confidence.
Yeah, and that brings me to something else I was hoping we could touch on, which is the creatinine. I wonder if there is a good way to think about the creatinine fluctuations we see in cardio-renal syndrome. What about you, my dear friend Hisham?
Yes, Hussein is exactly, it's a multifactorial. The fluctuations in the serum creatinine from the dilutional effect to the actual decrease in renal blood flow from excessive diuretics. So, to my knowledge, it's often we say diuresis through a creatine pump. However, I am with you completely, and I'm really not sure how much is too much. What about you, Amr?
Yeah, that's a very challenging situation. There is actually studies that show you are not better off when your creatinine gets better. This paradox is very important because, for example, the dose trials showed that if your creatinine got better, you had higher mortality than if your creatinine got worse during hospitalization for decompensated heart failure. And multiple other trials showed the same paradoxical effect. So I think the term permissive hypercreatinemia is a great term, and we have to have a good tolerance for a lower GFR and higher creatinine when we diurese our patients with cardio-renal syndrome. Similarly, the term permissive edema is also a brilliant term because we need some degree of edema in patients with severe left ventricular dysfunction and advanced CKD. Otherwise, this patient will be dry, will be hypotensive, and will have poor outcome.
Yes, so patients with decompensated heart failure, for example, whose creatinine initially rose up by 30% from their baseline with diuresis, actually did better than those whose creatinine went down right away with diuresis. This rise is usually not because of actual acute kidney injury or tubular injury. Is it correct, Roland?
Yes, Dr. Hisham, but we always follow creatinine in non-dialysis patient, and if I heard, oh, the creatinine is getting better, that was reassuring. It sounds like that might not always be true, and the permissive hypercreatinemia, as Dr. Amr said, is a new title which we have to consider it later on.
Thank you, Roland. So I think that the key point really is that a creatinine rise that does not always mean nephrons damage or injured nephron. And in the cases of decongestion, an additional reasonable where creatinine might look worse is looked for. For example, hemoconcentration, the creatinine, if you are diuresing well.
Absolutely, Professor Hesham. And I think we see this in several other circumstances in medicine and nephrology. And for example, when we give RAS inhibitors or SGLT2 inhibitors, we expect up to 30% increase in serum creatinine and reduction of GFR. And actually, this is healthy because this means that the intraglomerular hypertension is improving, and this will have a long-term better outcome for these patients.
Yes, I guess this is right. With these medications, we're helping each glomerulus work less hard at actually protecting them from getting too worn out in the long term.
Yes, I also agree. These drugs have been proven in the long run to really give the kidneys renal protection, the RAS inhibitors, and then, of course, the new kids on the block, the SGLT2 inhibitors. But we know that these drugs actively reduce the GFR by lowering glomerular pressure. And in the long run, as Dr. Hesham says, reduces the workload of each glomerulus. But all of these numbers going in the wrong direction really brings me to an interesting fact that it is actually a sign that the drug is working by reducing the intraglomerular pressure.
Yeah, and just to clarify, we are talking about a 30% to 50% creatinine bombing from their baseline. So not the creatinine they came into the hospital with. What about you, my friend Hesham?
Yes, Hosam, but I think from the clinical point of view, we have to explain that to the patient and the relative. As if you have, for example, a creatinine of 3 and it goes to 4, it increased by 33% basically. It will scare people, correct?
Absolutely, Sham. I think there is more and more evidence nowadays that more intensive diuretic therapy aiming to restore the compensation and with more rapid decongesting our patients is beneficial despite temporary increase in serum creatinine. Furthermore, an aggressive approach with rapid resolution of fluid overload and decongestion may even have nephroprotective effect and long-term better outcomes. Sounds good. So let's try to answer this question, Alia, regarding the diuretic resistance and diuretic response. Which one of these statements is incorrect? Okay, so all of them are correct except one. You need to choose this one. First one is loop diuretics have good diuretic or natriuretic effect below a given plasma threshold. Second choice is the brain natriuretic peptide and the N-terminal pro-BNP play a major role in counterbalancing the enhanced potentials for sodium and water retention caused by upregulated RAS system. Third option is in patients with heart failure, remodeling of the distal nephron is responsible for diuretic resistance. The fourth option is natriuretic peptides are elevated in patients with CKD irrespective of the heart failure. And the last option is to date only associative but not causative relations between hypoalbuminemia and the reduced effect of loop diuretics and, of course, diuretic resistance have been demonstrated. Which one of these statements is incorrect?
Okay, I don't think loop diuretics can be effective below a given plasma threshold because most drugs need the good or like target threshold so they can have a good effect. So this is a definitive incorrect answer.
Very nice. I think this makes sense, especially when it comes to diuretic, because loop diuretics have good diuretic effect and natriuretic effect only when the plasma concentration level goes above the ceiling or the threshold. Just let's talk a little bit about diuretic failure and diuretic resistance and what is the difference between diuretic failure and diuretic resistance. So diuretic failure is inability of diuretic to achieve target negative fluid balance. So if your target fluid balance, say, is 1 liter or 2 liters a day, and you fail to, attain or achieve this target, so that's a diuretic failure, regardless of the dose, okay? But diuretic resistance is when you fail or you are unsuccessful to use the diuretics. And also, if you are no longer be able to use it because of the safety issue, not only because of efficacy issues, so either lack of success or response, or presence
Side
of
effects, maybe.
right, or adverse events, so you cannot get the good response or the proper dosing, and now you need to stop the loop diuretic. So loop diuretics have a little diuretic or natriuretic effect below a given plasma concentration level. This is what we call plasma, threshold. And above this threshold, the patient will have sharp increase in the response. So we really need to attain such level or threshold. And the concept of diuretic resistance involves the adaptation and the remodeling of tubular kidney cells, especially in patients with heart failure, because heart failure, it causes remodeling of the distal nephron secondary to hyperplasia and the hypertrophy of tubular cells. And of course, this can induce resistance to diuretic. in patients with CKD, when the GFR goes down, the reuptake of the sodium in the ultrafiltrated bitubular cells is down regulated. So there is less room for further increment in natriuresis by loop diuretics, leading to diuretic failure and diuretic resistance. So that's very common problem in patients with advanced CKD to see the diuretic resistance and the failure. Patients with heart failure often have high concentration of natriuretic peptides. These natriuretic peptides have a major role in counterbalancing the enhanced potentials for salt and water retention caused by upregulated RAS system. And again, natriuretic peptide has also been elevated in patients with advanced CKD, even if they don't have any heart failure. This scenario blunts the response again to diuretic response. Here are some references, 2024, 2023, if you want to dig more and read more about diuretic resistance, dosing, and diuretic failure.
All right, thank you very much for recapping that and understanding the basic mechanism for such patient. So we follow the urine output and urinary sodium for Miss Sarah, and unfortunately are not having much response. Her Lasix gets doubled, and eventually she is on a drip. And she is just urinating maybe around 1 liter per day, with a urinary sodium still low in the range between 40 and 50. What need additional approach? What do you think about that, Hussein?
I think this might warrant our attention to diuretic resistance. What's our approach here, my dear Dr. Amr?
I think as long as we don't have good renal perfusion, as long as we have the effective renal plasma flow is low, because of low cardiac output, diuretics are not going to work. I think our main emphasis and main focus should be on improving the cardiac output that would possibly improve the effective renal plasma flow and the renal perfusion, so the patient will be responsive to the diuretics.
Okay. Another reminder, if you are just rising up the diuretics and so adequate response, could there be something else affecting kidney perfusion, like how low cardiac output or ascites?
Yes, Hosam, it should be all that excluded. So let us say that we are very confident and assured that we don't have additional factors and things like low cardiac output or ascites impacting flow to the kidney, and we have to be sure about that. At this point, I have different features for metolazone or chlorothiazide as additional diuretic posters.
Well, I found that oftentimes in the outpatient setting with heart failure patients who are diuretic resistance, we tend to reach for metolazone, which has a really long half-life.
I completely agree, Craig, with you. It's a long-acting diuretics, and it's very nice in this way versus, for example, the hydrochlorothiazide, which is short-acting. So IV chlorothiazide has a rapid onset of action, but it only lasts about 2 hours or so. I think metolazone in the circumstances might have actually a better response.
Agree with you, my friend. And then clinically, there is no real difference between the effect of metolazone or chlorothiazide. I think really the difference to know is that IV chlorothiazide is faster, has faster onset, and another practical point, more expensive. So we should emphasize on the pharmacokinetic of these compounds.
Yes, Hossam, I agree for the pharmacokinetics effect and the variabilities in between patients. So some clinicians prefer chlorothiazide, I think, because it feels like it works faster, and since it's an IV, you are not missing with oral absorption.
Yeah, Hesham, and you know there is another booster that I hear people talking about or tweeting about every now and then acetazolamide, guess that that's something good we can reach for, especially if that bicarbonate is starting to go up and they are still volume, I mean the patient's still volume overloaded. What about you, Rolla?
Yes, Professor. Acetazolamide carbon anhydrase inhibitor, it reduces proximal tubular sodium reabsorption. So by this way, it can help the loop diuretic function, leading to more potent and faster decongestion. Some studies suggested that it has a benefit in acute heart failure. And if the patient is alkalotic, they are preferred than being acidotic.
Thank you, Rola, for addressing this important point. So I think this is the ADVOR trial. It was randomized patients to loop diuretics plus acetazolamide or loop diuretics alone.
Absolutely. I remember that the acetazolamide arm, Dr. Hesham, did have increased the fraction excretion of sodium. They had decreased the length of hospital stay and the improvement of the decongestion. I believe this happened early as at 48-hour mark compared to the control group. So I really love acetazolamide. We started using acetazolamide in our ICU patients several years ago, and I think it works really good.
That's good to hear about acetazolamide, Amr. So I get one step forward for confidence using acetazolamide by clinical trials. It's really got a lot of fans. We should think about acetazolamide earlier, especially if the patient picarb is up to high 30 millimole or nearly 40 millimole, like in patients with COPD, and are still volume overloaded. Of the diuretic posters we talked about, at least in this episode, we have metolazone, fluorothiazide, acetazolamide. What additional types of things you think about that and we should be watching out for when we use this?
Yes, I think the things to look out for is that, some patients, especially when you don't keep a very close eye on them, they are so sensitive to this diuretic effect, especially from metolazone, that they become extremely volume depleted and can even go into rapid AKI development. And of course, you have to worry about electrolytes like potassium, magnesium, sodium, and calcium.
I completely agree with you, Craig. Definitely, we want to keep our patient potassium around 4 or more. There is actual data that hypokalemia is an independent risk factor for diuretic resistance. So the fear and the risk of hypokalemia is not only about arrhythmia or increased sudden cardiac death, but also about diuretic resistance. So electrolyte monitoring, especially potassium, magnesium, sodium, is very important, and repleting the deficiencies of these electrolytes is a cornerstone in treating patients with congestive heart failure.
Perfectly correct, thank you very much for that. We had definitely talked about keeping that serum potassium above 4 when we are worried about arrhythmia and things like we did a whole hypokalemia episode on this. But I always thought about hypokalemia actually making you respond worse to diuretics for sure.
Absolutely, Hisham. And I think you highlighted something very important because one of the hidden electrolytes is magnesium. So acetazolamide, loop diuretics, thiazide diuretics, they all lower down magnesium and also they lower down potassium. And you're not going to correct the potassium deficiency except you really correct magnesium deficiency first.
So it sounds like mainly be careful about those pesky electrolytes. Maybe reach for renin-angiotensin-aldosterone inhibitors like spironolactone or as our friends here. And of course, watch the volume status, especially when turning on the boosters.
Yes, Hussein, for sure. Or after that, let us say, for example, you try everything and your patient is still not urinating much and is still congested. And your attending is like to find another way to remove such volume overload status. So the patient may need dialysis or at least aquapheresis.
Well, I agree with that, and I really don't mind being called to do this because I really love doing dialysis, and I think it works well in certain patients in whom we use it for the right indication. So, of course, when you've now used all your sequential nephron blockade strategies, and it might become time to use SCUF or even intermittent hemodialysis or continuous renal replacement therapy. But not without its difficulty, because once again, we have this age-old question: when is the right time to start? When is the right time to abandon diuretic efforts and to start dialysis? Because leaving a patient fluid overloaded for too long can yield very serious consequences of the chronic fluid overloaded state. Also, the matter of using intermittent modalities versus low efficiency CRRT therapies is also important, because many of these patients may be left with long-term dialysis dependency issues.
Okay, true, Dr. Craig. I don't think keeping the patient congested, desaturated, overloaded, impending pulmonary edema is a wise thing for a long period, especially after using higher doses of different types of diuretics, in my opinion. If I have tools to get their own kidneys, to get out all of this fluid, excess fluid, I want to maximize those options as I can before I go to dialysis. But of course, we have this patient where we did everything with them and we failed.
I totally agree, Rolla. That holds true. I think that's a great reminder about what we sometimes put our patients through.
Okay, I think we have a room now for another question, and Alia is still with us. She's patient and she is trying to help our patient and trying to, answer the question. So, if this patient that we have with acute decompensated heart failure have persistent congestive symptoms despite very high dose of furosemide, and we decided to combine with other diuretic, on top of the loop diuretic, we need to combine something else for better response. Which statement is correct? Okay. So the first statement is thiazide diuretic promote natriuresis and diuresis. They are used as first-line treatment in cases of acute decompensated heart failure because of high potency, especially when used as monotherapy. Second statement is metolazone, which is thiazide-like diuretic, has additional inhibitory effect on sodium and chloride reabsorption in the collecting duct. The third choice is adding acetazolamide 500 milligram once daily to IV loop diuretics resulted in higher cumulative urine output and natriuresis. The fourth option is the SGLT2 inhibitors are weak diuretics, and recent evidence limited their use to improve heart failure only with patients with preserved ejection fraction. The last choice is vasopressin receptor antagonist, have been studied in patients with acute decompensated heart failure, and they showed improvement in long-term morbidity and mortality. So all of these options are wrong, except one. What do you think, Alia?
Okay, if we go with the first one, thiazides are not the first line in treatment. Usually we use loop diuretics. The second one is also incorrect, as the metolazone usually works on the distal convoluted tubules, not the collecting ducts. Adding acetazolamide, I agree with this one. It increases its cumulative effect. It's true, so probably C is the correct one. D are weak diuretics. Recent evidence limit their use. Actually, I think SGL2 inhibitors are the trendy drugs. They're not limiting their uses anymore. They're actually promoting their use with most patients, especially with heart failure. And vasopressin, vasopressin receptors have been studied to show improvement on long-term No, there's no, I think there's lack of data that support the long-term effect of morbidity and mortality. So I would go with C as adding acetazolamide 500 milligram once daily to the IV loop diuretics can result in a higher cumulative drug, yes.
Very
C.
nice. So you said thiazide diuretics work on the distal nephron, right?
Yes.
And loop diuretic, where does it work? From its name, on the lobe of Henle, right?
Yes, loop of Henle, yeah.
Especially in the ascending limb of the lobe of Henle, the thick part.
Loop of Henle.
Okay. So which diuretic works on the proximal nephron, the proximal convoluted tubule? Should be the third option. Acetazolamide works on the proximal nephron. Okay, let's see. So very good suggestion from Alia. I think option C is a correct answer, because adding acetazolamide 500 milligram once daily to the IV loop diuretics in several randomized clinical prospective studies showed higher cumulative urine output, natriuresis, and diuretic effect. So thiazide diuretics, combining diuretics together usually have synergistic effects because they work in different parts, and this is recommended by most of the societies. So we have short-acting thiazide diuretics like hydrochlorothiazide, and we have longer-acting thiazide diuretic like chlorothalidone. Then we have thiazide-like diuretic, which is a metolazone. So these three medication, or the thiazide group at large, they promote natriuresis and diuresis by inhibiting the sodium reabsorption, about 3 to 5% of the luminal sodium reabsorption in the distal collecting duct. They are rarely used as first-line treatment, as Alia said. They are usually second-line treatment. Usually loop diuretics are the first-line treatment, and they are not used as monotherapy, usually in patients with congestive heart failure. So they are used usually in combination with others, especially the loop diuretics. So thiazide diuretics, they are very commonly used in combination with loop diuretics. That's what we call sequential nephron blockade. So we use something for the loop of Henle, which is the loop diuretic, and something for the distal part of the nephron, which is the thiazide diuretics. Their efficacy is reduced in patients with CKD, and actually below a GFR of 30, their response is usually minimal. The exception of this is metolazone. Metolazone has, a good effect even with GFR of 15 or 20. So you can still use it with lower GFR compared to the rest of thiazide group. The greater efficacy of metolazone compared to common thiazides in patients with reduced kidney function is probably because the additional inhibitory effect of sodium and chloride reabsorption in the proximal convoluted tubule. So metolazone, is different from the rest of thiazide diuretic because the rest works mainly in the distal nephron, but metolazone has also an action on suppressing the salt and the chloride reabsorption in the proximal nephron. So this might be the explanation that patients with advanced CKD can get a still good effect from metolazone. What about acetazolamide? Acetazolamide is very different because it works in the proximal convoluted tubule, and it blocks the sodium reabsorption and improves the natriuresis. It's carbonic anhydrase inhibitor. And actually, we use it also to correct metabolic alkalosis because it mitigates the neurohormonal activation through reduced renin activity and promoting greater chloride concentration in the macula densa. So if the patient develop metabolic alkalosis secondary to use of other diuretics, actually acetazolamide can also be used not only to augment the diuretic response, but also to improve metabolic alkalosis. Although the net diuretic effect of acetazolamide is modest, it's not very strong, but the combination with the furosemide and the other loop diuretics increase the efficacy. It has synergistic effect. In multi-center randomized clinical trial in patients with advanced acute decompensated heart failure and fluid retention, adding acetazolamide 500 milligram once daily to the IV loop diuretics resulted in higher cumulative urine output, better natriuresis, and better improvement of the volume status. Of note, the mineralocorticoid receptor antagonists, the MRAs, they are potassium-sparing diuretic. We haven't talked about them yet. The aldactone, the eprinone, and the more recent one, the ferrinone, which is non-steroidal, more selective mineralocorticoid receptor antagonist, and it causes actually less hyperkalemia compared to the rest. This medication has been shown to improve mortality in patients with congestive heart failure, especially with reduced left ventricular systolic function. So if the ejection fraction is less than 25%, these medications actually might be helpful to improve the patient survival. A consensus of experts recommends the use of MRAs in acute setting, and it should be individualized with close monitoring of electrolytes, especially in patients with advanced CKD because of the hyperkalemia. And also, you know that the rest of diuretics, like thiazide diuretics, the loop diuretics, they cause hypokalemia. So the combination of MRA and the thiazide or loop diuretics is helpful in this regard. When it comes to SGLT2 inhibitors, recent evidence, as Alia said, supports their use to improve heart failure outcome and quality of life in patients with advanced heart failure, acute decompensated heart failure. And the benefit appears to be consistent with both heart failure with reduced ejection fraction and also with preserved ejection fraction. What about VABTANs, the vasopressin receptor antagonist? It has been studied actually in patients with acute decompensated heart failure, but despite some evidence indicating that they might improve signs and symptoms of congestion, the Everest trial, which is a big RCTs, didn't show any improvement of long-term morbidity or mortality. Again, here is a table of different classes of diuretics from carbonic anhydrase inhibitors, the acetylzolamides that works proximally to the loop diuretics that works on the ascending loop of Henle, the thiazide diuretics, which works mainly in the distal part of the nephron, potassium-sparing diuretics, the MRAs, spironolactone, eprinone, and amiloride. Actually, didn't talk about amiloride, but also ferrinone that works also on the distal part of the nephron. SGLT2 inhibitor, it works proximally like the carbonic anhydrase inhibitor. VABTANs, like the tolvaptans and the other VABTANs, works on the distal nephron. So ferrinone has been approved, I think 3-4 years ago, FDA approved, to be used mainly in diabetic patients with CKD, but also it has been associated with improvement outcome in patients with heart failure. One of its major advances is because it's selective non-steroidal MRAs, it causes less hyperkalemia, so it's helpful in patients with advanced CKD. We have very good 2 trials, the FIDILO and the FIGARO DKD studies. Both have shown that it reduces the risk of cardiovascular events like heart failure, hospitalization, cardiovascular death in patients with CKD and diabetes. So the main usage is diabetic CKD patients. Here are some references again if you want to read about these diuretics. And with that, I think that's very informative questions. And
so let us do one of the updating on Miss Sarah. Unfortunately, we have bad news that after doubling the dose of IV furosemide infusion, we didn't have or found an adequate response. What about the good news that we started adding metronidazole and acetylzolamides, and thankfully, she is starting to feel better without needing dialysis. So she is away from the machines. Her creatinine started to downtrend quite back to her baseline, preparing her to be discharged home soon.
Yes, my dear Dr. Hesham, and then from here we have to really think about her chronic kidney disease management, and that brings us back to the guideline directed medical therapy, GDMT, on heart failure medications and chronic heart disease, in chronic kidney disease.
Yes, Professor Dr. Hesham and Professor Dr. Hesham, nice update. GDMT, the four pillars of heart failure, especially heart failure with reduced ejection fraction, renin-angiotensin system inhibitors, beta blockers, mineralocorticoid receptor inhibitors, and sodium glucose transporter, co-transporter inhibitors. But what about their use in CKD patients with different GFR?
I think, Rola, they are completely underutilized because of the fear of their effect on the kidney function. However, we should highly consider adding this medication after decongesting our patients. We need to recognize that these are the first-line medications for heart failure in patients with chronic kidney disease.
Okay, Dr. Amr, so that's quite easily said in CKD patients 1 through to 3, where obviously starting the RAS inhibitors and SGLTs are so important because of their proteinuric kidney and heart protection effects. But it becomes really tricky when the eGFR starts creeping into the stage 4 and stage 5 range.
Absolutely, Craig. I think what we need to do is we need to initiate SGLT2 inhibitors as long as the eGFR is above 20. It showed improvement of cardiovascular outcome and patient survival, even with patients with reduced and preserved ejection fraction. So we should remember always to initiate this medication. This doesn't mean that we shouldn't start SGLT2 inhibitor below GFR of 20, but again, it is just well studied when the GFR is above 20. And I think in the near future, we have more and more studies examining their effects in patients with advanced CKD, including dialysis patients.
For me, I do agree. The biggest teaching point from that episode is that it's probably safe to continue the sodium glucose transporters type 2 inhibitors, even if the estimated GFR drops down below 20, as long as it is not giving the patient any issues. What about you, Hesham?
Yes, Hossein, sure. You should continue sodium glucose transporter inhibitors until the patient in dialysis stages. Unless that, it is very similar story. Who fear from the CKD progression, we shouldn't stop RAS inhibitor as well.
Yes, Professor Dr. Hesham. As a matter of fact, cardiovascular diseases are a leading cause of death in patients with advanced CKD. The combination of RAS activation, sympathetic overactivity, and oxidative stress all may contribute to increased cardiovascular mortality and associated with CKD. As a result, discontinuation of RAS inhibitors, I think, will cause a big problem, and we have to continue this because there's no reason to stop them at all. That will increase the mortality with our CKD patients, unless we have problem with potassium and there's a potassium issue, we have to keep them going on.
Yes, I agree, Rola. The most feared acute complication is hyperkalemia. Hyperkalemia is almost like the hidden assassin. We want to use these drugs, the best drugs, but they all seem to have hyperkalemia-inducing mechanisms on the kidney. There are obviously options of potassium-binding resins such as Elsayed or the newer agents such as sodium zirconium salicylate. Dr. Hesham, do you use them?
Yeah, sure. Thank you for highlighting the potassium binder. But to highlight that when starting sodium glucose transporters, at least for the first months, the incidence of hyperkalemia is low. And one of my favorite things is to start both sodium glucose transporter with RAS inhibitor, adding the third pillar of mineralocorticoid receptor antagonist, since sodium glucose transporter can be protective against serious hyperkalemia for those drugs.
Good note, Dr. Hesham. And speaking of mineralocorticoid receptor antagonists, I do hear about finerenone making an appearance on the scene as one of the most new congeners of aldosterone antagonists, and I believe is more selective mineralocorticoid receptor antagonist than the non-steroidal MRA that we know is spironolactone and has been shown to cause less hyperkalemia. Hesham, what do you know about that?
So I think that, yes, mineralocorticoid receptor incidence of hyperkalemia is high. However, with the new one, the phenrenone, the incidence of hyperkalemia is less. And according to the guidelines, don't start mineralocorticoid receptor antagonist phenrenone unless the serum potassium starting point below 4.8 millimolar.
Back to Mrs. Sarah. If the patient clinically improved, do you just discharge her with the same oral medication on the same diuretic she was on before torsemide? And when will be her next visit, clinic visit?
All right, with all that said, whenever you discharge someone from hospital, you need to make sure that you have very close follow-up. And this is critically important because, as we've discussed earlier, these patients can easily be over-diuresed or overshoot their markers and develop electrolyte problems. We often find that after you've prescribed someone IV diuretics, their oral diuretic sensitivities will improve with time. And we always wonder what dose they need to be on actually.
Very good, very good. I think the patient was treated very well, and 6 days of hospitalization, her dyspnea and edema has improved, and her blood pressure looks very stable. Now she is on room air with oxygen saturation of 93%, and her last furosemide dose was decreased to 80 milligram every 12 hours, still IV, and other diuretics were stopped 2 days ago. She's making about 3 liters of urine every day. She is very adherent to her medication. Her creatinine has improved back to her baseline of 1.6. And we are preparing for discharging this patient. And now we need to switch her IV diuretics to oral diuretics so she can take it at home. And we scheduled her appointment with her cardiologist and with us in our nephrology clinic a week. And now the question is, if the patient refusing to return to torsemide before hospitalization, you remember she was on torsemide. So which of the following is the most appropriate diuretic regimen for discharge? Do we need to explain to her the benefit of using torsemide and insist of returning back to her home dose of torsemide? Or we need to start oral furosemide 80 milligram twice daily, or 160 milligram once daily, or switch to Biomix 4 milligram once or twice. What do you think, Alia?
Okay. First, I think the patient has her own right to choose medication. If she doesn't want to go back to torsemide, I cannot force her. Especially as she was responsive well to IV furosemide. So I would suggest we'd go with the oral furosemide twice, as she was on IV twice daily. And usually those when we switch from IV to oral, we go to 1 to 2.5 times. We started with the gradual approach, so I would go with B.
So 80 milligram of furosemide.
Yes, twice.
Okay, I think this makes sense. So giving her the same IV dose, you remember she was on 80 milligram.
Yes,
IV
80 twice. Yes.
But you said you want to double it,
No, I said we start, we have from 1 to 2. This is our range. So I'm one of the persons where I like to go with the lower dose and increase it gradually rather than go with the higher dose and going down.
Good. Let's see exactly how we can convert IV diuretic, various IV diuretics to oral form. First, we have to understand that furosemide is absorbed from the stomach and duodenum. Similarly, although the gastric absorption is slow and include first bypass metabolism. So the bioavailability of furosemide is low, about 50 to 60%. So the IV form, because it goes direct to the blood,
More
half
effective.
of, yeah, the oral dose would be equivalent because the first pass mechanism and the lower bioavailability. So if you need to convert IV diuretic to oral diuretic, you actually need to double the dose to get the same effect because the bioavailability is about 50%. In cases of biomix, it's more than 80% bioavailability, 80 to 100% actually. So you don't need any conversion. The oral dose is the same as IV dose. The difference between the bioavailability of furosemide compared to biomix is very important to understand. And if you want to get the same response from biomix, is oral equal to IV, but when it comes to Lasix, you need to double the dose when you want to get the same response that you are getting from IV when you switch to oral therapy. Okay? Of course, by the end of the day, you need to watch the patient symptoms and signs of volume overload, the urine output, the congestive symptoms to see, because there is some, inter-patient variability between this medication, and we should have clinical evaluation and follow-up of our patient, especially also if you get a kidney disease, the response will be a little bit different, the bioavailability will be a little bit different. If you have gut edema because of severe hypoalbuminemia or severe congestion, also the response might be lower. So all of these factors we need to consider. And actually, doses that induce a concentration greater than the ceiling may increase toxicity without increasing the response. So giving higher doses can induce ototoxicity, nephrotoxicity, neurotoxicity, and electrolyte imbalance, hypokalemia, hypomagnesemia, hyponatremia. So we don't want this to happen. And you have to remember also that furosemide is metabolized completely by the kidney. There is few medications that are metabolized by the kidney. You remember, most of the medications are metabolized in the liver,
By the liver.
secreted in the kidney, but furosemide is actually metabolized by the kidney, but furosemide is metabolized mainly by the liver. So you have to consider this when you are giving this medication to patients with kidney failure or liver failure. Okay, so this patient, let's go back to this patient. This patient responded very well on 80 milligram IV of Lasix twice a day. So now we need to go a little bit down because we don't want to over-diurese the patient. The patient is, in the plateau stage. She's back to her baseline. So I think for, 80 milligram BID oral should be okay. If she will stay in the hospital, probably we are going to use 40 milligram IV twice, which is equal to the 80 milligram oral twice. So we can do this. Then we are going to see her in the clinic within a week to evaluate the response. Okay. And the other thing, as Alia said, we cannot enforce the patient to, to get a medicine that she doesn't like, especially if there is no argument that furosemide improves the patient outcome. I mean, we talked about it, that, the transform heart failure study didn't show a significant difference when it comes to furosemide compared to furosemide. Okay. The other choice would be increased diuresis and could cause hypovolemia and hypokalemia. So we need to appropriately use a good and rational diuretic dose. And here is a conversion. And when you want to switch, for example, from furosemide to Biomix, 1 milligram of Biomix is equal to 40 milligram of Lasix, equal to 20 milligram of furosemide. So that's important to remember. Also, when you want to switch to oral to IV, Biomix is 1:1, so the same dose, while furosemide, you need to double the dose of the IV when you switch to oral to get the same response. Here is a bioavailability is about 50–60% in furosemide, but it's much better for furosemide Biomix 80 to 100. The half-life and the duration of action when it comes to Biomix, it's the shortest, has the shortest half-life, and also the shortest duration. So it works, the half-life is 1 hour to 1.5 hours, and the duration is 4 to 6 hours. The torezomide is the longest acting, and it takes 3 to 4 hours. And the duration is 6 to 16 hours, so it's longer acting. When it comes to the furosemide, the half-life is 1 hour, 1.5 hours to 2 hours, and the duration is 6 to 8 hours, so it's an intermediate. So Biomix is fast acting, and it doesn't, exist in our system for long time, while torezomide is, slower and longer acting, and furosemide is in between. So it's good to remember those. And with that, here are the references. And I really thank you so much, Alia, for helping us to understand and to answer these questions. Thank you.
Thank you. Thank you so much, Doctor. And I hope you have a great night. And we'll definitely meet soon. Have a great
Thanks.
night.